Welcome back to another episode of Oncology for the Inquisitive Mind with your co-host, Dr. Josh Hurwitz, that's me, and the other co-host who has a beautiful collared shirt on today, or, polo, some might say, Dr. Michael Rodriguez Fernando. Michael, it is so good to see your face. We're recording here in sunny Melbourne and very, very sunny Brisbane. And the thing is that you'll be able to see us on YouTube if you so desire. I'm mostly shaved. Michael, I don't know if you have today, but it's good to see you. How's things?
It's good, Josh. And it's always good to be involved in a YouTube phenomenon or emerging YouTube phenomenon. At least that's what we hope. That's what our parents say. But yes, we are doing another episode on colon cancer, which
we are. Yeah, it's going to be dynamic.
It's dynamic, and we'll be examining all of the nooks and crannies, the niches, some might say, today, following on from our episode that was full of ideas and also full of some technical gaffes last time. But hey, we're learning, and
can only get better. Michael.
Yeah, start at the bottom, and now we're here. Josh, I started last time, so why don't you lead us off with the Niche 2 trial?
I will. And Michael, just before we do and we hit the ground running, so to speak, well, we're already not, I have to tell you that I've been taking a couple of screenshots and sending them to your wife just for prosperity's sakes. Just to open disclosure.
Goody. So now her and everyone in YouTube will know what I'm doing.
Well, yeah, exactly. That she's like, oh, that's fun, because I was telling her what we were doing. So let's talk about the Niche 2 trial. So this is a neoadjuvant immunotherapy in locally advanced mismatch repair deficient colorectal cancer. So my presentation is going to be relatively short. There's some just really an interesting graph to show. I think that's the main thing. The background is that 15% of non-metastatic colorectal cancers deficient in the mismatch repair, well, a couple of the mismatch repair mechanisms. And so that's important for a number of reasons. The first is that pathological response of those that just get chemotherapy, especially in the neoadjuvant sphere, is only about 7%. So they don't actually respond that well to chemotherapy alone. That's the first point. What we knew at the point of, I think, publication of this, and I think it was published in 2024, but obviously their little blurb predates that. They knew that immunotherapy blockade is great in the metastatic space, especially when it comes to progression-free survival. And the original niche study, this niche study was that neoadjuvant immunotherapy and novel IO combinations could potentially work in early stage colorectal cancer, because we're always looking for things that aren't just chemotherapy. Chemotherapy is great. It's the cornerstone of a lot of our treatments, but maybe there's something better. And there will be sometime in our lifetime, we'll wipe the floor of even what we're talking about today. So the method of this trial was that patients had to be deficient in it was a phase 2 study from memory. Yeah, it was a single group study, phase 2, where there were dMMR, there was stage 2 or stage 3 colorectal cancer. They had to be resectable and have no sign of metastatic disease. The sample size was going to be about 30, and then they eventually added a couple of high risk, being T3 or node positive as well. MMR status was determined, and if you had deficiency in those, then you would clarify, you would be allowed to participate in the study. You were given 2 doses of nivolumab, and the first dose was also given with ipilimumab, which is the classic CTLA4 inhibitor that I'm sure you've all heard of in the past, coined and came to greatness in the world of melanoma. Primary endpoints, Michael's smiling. Thank you. I'm trying to be a bit more engaging. The primary endpoints, the first was safety. Look, I don't think anyone ever had any concerns when it came to safety with this, because overall, if you look at the side effects from immunotherapy, even the CTLA4, if they have side effects, you'll be able to manage them with steroids. You're essentially a dermatologist.
I will say, I think in this particular study, Josh, a big part of the safety, and I can see that you've got it written in your notes here, is whether giving immunotherapy before surgery causes delays to surgery as well.
Yes. Well, that was the big safety endpoint. That was kind of like they want to make sure that you can get to surgery. So I guess the question is, if you give the treatment and it shrinks the cancer, but then you can't get to surgery, that is less good. Some would say bad.
Some would say bad.
And then the secondary endpoint was 3-year disease-free survival. Sorry, the other primary was 3-year disease-free survival. And the secondary endpoints were pathological complete response and results from translational genomic analyses. So if you look at the screen, and for those that don't see the screen, you can still hear my somewhat nasally voice. 33 patients were assessed for eligibility for this study. One did not meet criteria and withdrew consent. And then 32 were enrolled in the niche study. And overall, 115 were included in the cohort, and 111 were included for the efficacy analysis. So of this, what we found was as follows. Let me just move to the other slides. You've got the demographics here, and I don't know if you can see them. There was about slight predominance for females. Average age was about 60. Most had a great performance status. Majority were white. And if you look at the tumor breakdown, there were actually a couple of T4s as well, which probably should not have been included too. But here you can see definitely responded. Okay, this is the slide that we actually want to look at, Michael. The results for surgery, which is so all the patients underwent surgery and there was 100% zero resection rate. So that's actually a tick. The median time from first dose to surgery was 5.4 weeks in that safety analysis. They sort of had, I think it was 2 to 6 weeks plus or minus 2 weeks post the defined time that they wanted to have surgery, and there were no new safety signals either. So that was the other important thing to talk about. There have been trials when they've sort of included immunotherapy with other drugs and it hasn't gone so well. Grade 3, there was about sort of 13%, so not too bad. And anastomotic leakage or wound infections was about 5%. So I don't know what it is in the standard, Michael, but I think that's just something to bring up. You'd get that also with chemotherapy as well. But this is the golden, Michael, this is the golden, waterfall plot, right? What you see here is as follows. And for those that can't see it, I will explain it to you in the best of my ability. There's lots of blue lines and they kind of go down.
Paint us a word picture, Josh.
Paint us a word picture. So what we're looking for here is major pathological response, right? And we saw a major pathological response, which is less than or equal to 10% of residual viable tumor in 95% of patients, right? So there was a major pathological response in the majority of those. Those that had a complete response was 67% of patients. So with just 2 doses really of treatment, 2/3 of patients had really no cancer and about 4% had a partial response. So you see all these really beautiful blue lines that just kind of go and go and go, and it's absolutely lovely to see. So what does this show? It shows that this cohort of patients are exquisitely responsive to neoadjuvant immunotherapy, right? And the question that it did not answer and that I could not find was actually what the 3-year DFS was. It didn't say it in the trial. Maybe it's come out. I had a brief look on Google. I could not find it. The secondary question I also want to know, and I don't know, and Michael, you're probably going to bring this up anyway, is as follows. Does it reduce recurrence rates? Stage 2, stage 3, right? Does it reduce recurrence rates because there's still a percentage of patients who will recur? Or do you then give chemotherapy afterwards? Or is it just neoadjuvant, then surgery, and then you monitor? All of these things I don't actually have answers to. And I think time will give us that answer. But I guess this was a proof of concept study. It was a phase 2 trial. It wasn't a phase 3. So what would you do versus standard chemotherapy? Would it be chemotherapy plus immunotherapy in a cohort of this? I don't know. But there's been a number of other trials similar to this, which have shown really similar outcomes with other immunotherapy agents as well. So it's exciting. It's exciting times for that 15% of patients.
It is very exciting. I will say, Josh, that because I looked at this for another presentation that I gave a while ago, and apologies that I didn't give you these notes, but they did say that there were no disease recurrences after 3 years of follow-up. And we do know that for colon cancer, I think it's something like 90% of recurrences occur in the first 2 years, 97% or something about that within the first 3. You're always going to have a handful of patients, for whatever reason, have recurrences very late. But for the overwhelming majority of people, once you get to 3 years, that's it, you're done. And so to have no disease recurrences for a relatively not small population, it was more than 100 people at 3 years, is fantastic. I think the main competitor, and we've spoken about this study before, is Atomic. which came out at ASCO, which was chemotherapy plus adjuvant atezolizumab, not in the neoadjuvant setting, in the adjuvant setting. And that showed very good responses as well. And if you listen to our interview with Dr. Jenny Seligman, if you haven't, number one, what the hell are you doing? Go and listen to her. She's fantastic. But number two, she points out a lot of very important logistical things. You need buy-in from the gastroenterologist, buy-in from the surgeons. This is in the context of her doing Foxtrot. You need buy-in from radiologists because you're radiologically staging these cancers because you don't have the pathological specimens at this stage. And you also need the pathologist's help to get the dMMR status or the MMR status in a reasonable time. So it's logistically quite challenging, but you see these results. You see this famous Shalabi plot, and it is really, really good. And it's a pattern as well because there's also a very small study, I think there were about 20 people maybe, of rectal cancer and using dostarlimab, so a very similar sort of thing. And every patient had a complete pathological response for patients who are MMR deficient. Very small numbers, I think it's something like 2 to 5% of rectal cancers are MMR deficient. But the fact that we can do this is very exciting. It needs more work than the standard chop and then treat, but it's very exciting.
I guess the oncologist role is no longer the secondary or tertiary individual to see these people.
Exactly. And it makes our job more fun and more rewarding.
Yes, rewarding. I don't know if anyone having cancer is fun, but let's say curing cancer is fun.
Curing cancer is very fun, and it's something that we are not doing enough of. So, it's and you might say, Josh, that our career process is very dynamic, much like the study that I'm going to be talking about. How's that for a segue?
Terrible, but I love it. Keep going.
I was quite proud of it. I thought it was quite good. So the study that Josh is very skeptical, is Dynamic 2. That is the study that I'm going to talk about. And we have spoken a number of times in the last couple of episodes about circulating tumor DNA. And this is something that is becoming very, very widely tested, very widely used in trials. But at least in Australia, it hasn't sort of hit the mainstream yet. That's mainly due to availability. But what is circulating tumor DNA? Well, it is exactly what it says on the tin. It's biological material that is shed by tumor cells and goes into the systemic circulation. The exact mechanism of how this happens is incompletely understood, but it's thought to be genetic material release following apoptosis or necrosis of the cancer. And in the pre-treatment phase, this usually happens by a cancer outstripping its blood supply. And so it dies, explodes, and there's gunk, tumor gunk, you could think of it, in your bloodstream. So the idea that we can use this not only as a diagnostic tool, but to guide therapy is a major area of research and very, very exciting. And this study, Dynamic 2, was spearheaded by a former guest, very much a friend of the show, Professor Jeannie T, down at the WeHi in Peter Mac in Melbourne, Victoria, Australia. So very, very exciting to have these results on. Now, basically, as the 2 in Dynamic 2 suggests, this was a study that enrolled patients with stage 2 colon cancer. And the reason for this is that the benefit of adjuvant chemotherapy in patients with stage 2 colon cancer is controversial. The general recommendation is that you consider it for patients with high-risk disease, and the classic is someone with T4 disease or T4 primary, and the stage for that by definition is T4N0, so big tumor, no nodes. Anything more and it becomes stage 3. But as we said in the last episode, and after you finish listening to Jenny Seligman and then this episode, why not go and watch that one and maybe subscribe and give us a review while you're there. Leave a comment on YouTube if you're watching. But our current system of differentiating and risk stratifying colon cancer patients is crude. And we have patients who are thought to be high risk that never recur. We have patients who are thought to be low risk with disease that behaves very aggressively. So there is a bit of a disconnect there. And so the question here is, can we use CTDNA as an extra predictive mechanism, but also can we use it to guide treatment? And this is something that we talk about when we talk about these newfangled tests. I'm sounding really old when I say that, but newfangled tests is, you have this information. Brilliant. Oh, someone's CTDNA positive. What do you do with that information? What information or what inferences can you make with that information? Because if you just have it, it's kind of pointless. especially when it's so expensive. So, Dynamic was a phase 2 study, a randomized phase 2 study, however, and I will bring up the study schema, enrolling patients with stage 2, so that's T3 or T4, N0 and M0. You had to have no nodes and no metastases, colon or rectal adenocarcinoma. I think the main focus was on colon, however, with negative resection margins. And patients, as our YouTube viewers can see, were randomized 2-1 to CTDNA guided management versus standard management. The majority of patients had T3 disease and were deemed clinically low risk. So T3 disease, 85 versus 86 in the CTDNA and standard care arms, and low risk 60 versus 59% in the two arms respectively. And low risk was basically defined as non-T4 disease. So the standard treatment arm, as you can see in the schema there, pretty straightforward. It's standard management. So what you have is you have your tumor cut out and then you go straight to chemotherapy or not at the clinician's discretion. In the CTDNA guided management group, this is where things get interesting. So patients had a CTDNA sample taken at week 4 post-surgery and week 7 post-surgery. And patients who were CTDNA positive at either week 4 or week 7 were treated with either 5-FU by itself or doublet treatment, and this was at the clinician's discretion. Patients that were CTDNA negative at both week 4 and week 7 were not given adjuvant therapy. So this is where the application comes in, and this is where the study schema goes a little bit further than just, oh, this is a nice test to have. So the primary endpoint was recurrence-free survival at 2 years, and the risk of recurrence after 2 years. Josh is slow clapping me now because we are two old men when it comes to technology on this podcast.
I love being old. It's the best thing ever.
I think you love me acting old more than actually being old, I'll be honest. So if you get to 2 years after your surgery and after your chemotherapy, if you happen to have it, then you are pretty well out of the woods for the majority of people. The key secondary endpoint was whether patients were treated with adjuvant chemotherapy based on their CTDNA response and the recurrence-free survival amongst patients who are CTDNA positive and CTDNA negative. So 459 patients were enrolled, and let's go straight to the results. So there was no difference between the standard management and the CTDNA guided management on the 2-year recurrence-free survival. The RFS was 93.5 compared to 92.4%, with a hazard ratio of 0.96. And that's, you might say, oh, well, that's very, very disappointing. But you have to remember that what the first hurdle that these sorts of approaches have to make is that they are not worse than standard management. And so this is a really important hurdle for CTDNA as a concept to clear, and it has cleared it. There's also the potential for predictive value of CTDNA for certain treatment outcomes. So the 2-year RFS by CTDNA status is markedly different. 92.5% for patients who are CTDNA negative and 86.4% for patients who are CTDNA positive. The patients who had T3 versus T4, this was confirmed as a predictive factor independent of CTDNA status. However, and I'll share this very interesting tidbit as well. So you see this forest plot for those of you who are on YouTube, and you think, okay, well, this is sort of a survival forest plot. And you would be wrong, Josh. You would be very, very wrong. Because what this actually is this is a forest plot looking at the likelihood of receiving chemotherapy amongst certain patient groups. And so you can see here that patients with T4 disease were 2.5 times less likely to receive chemotherapy in the CTDNA group compared to the control group. Patients who had tumor perforation were also less likely, although that's not statistically significant. Patients without tumor perforation were 1.8 times less likely to receive chemotherapy. And patients who had poor tumor differentiation, very small numbers here, but they were 5 times less likely to receive chemotherapy in the CTDNA guided group compared to the control group. So when we are having the same sort of outcomes while giving less chemotherapy, I mean, that is really the goal of any oncologist worth their salt, to be honest. It's also a dynamic process. So patients who cleared their CTDNA had a 5-year recurrence-free survival of 97% compared to a 0% 5-year recurrence-free survival for those who did not, who were persistently positive. And that was, I think, from week 4 to week 7. If we expand that, the 5-year recurrence-free survival for CTDNA at the end of treatment was 85.2% for those who did clear with chemotherapy compared to 20% for those who were persistently positive as well. So the overall survival, and I think I'll share my final slide here at this point. The overall survival the overall survival for patients who were treated with who had chemotherapy and were CTDNA positive compared with the patients who were untreated, who were CTDNA negative at 5 years, had a hazard ratio of 3.3. So this is the other thing, and this shows some of the power of CTDNA, the potential power, that even if you have chemotherapy, if you are CTDNA positive, your outcomes still appear to be significantly worse. So where does this leave CTDNA? Is it ready for prime time? And my take from this is it is absolutely part of the equation. But for some of our older listeners who are familiar with that seminal TV show called Scrubs, which is having its revival pretty soon at time of recording, there's a great series or scene at the start where the main characters are introduced to their resident, and JD, the main character, imagines him saying, "I'm a tool. I am a tool. I am a tool, an unbelievably annoying tool." CTDNA is not annoying, but is absolutely a tool in the armamentarium of the oncologist. We shouldn't rely on it. We shouldn't just use it and not use our brains. And I think we can see this by the fact that T4 disease, compared with T3, is an independent risk factor. So CTDNA is not the be-all and end-all, but the information coming out of Dynamic 2 is very, very interesting, both from a therapeutic perspective and a prognostic perspective. If we had access to CTDNA, and we don't have access to it in Australia at the moment, unfortunately, the way I'd think about it is if you are T3 and CTDNA positive, absolutely give adjuvant chemotherapy because you want to maximize outcomes by trying to clear the CTDNA. And you can use that as a marker of treatment success. If you are T4, regardless of CTDNA positivity, I would still give treatment. But if you are T3 N0, and remember this is stage 2, then you would have that discussion, but you would probably lean towards not having treatment if they're CTDNA negative. The other thing, final thing to mention, Josh, before we wrap this up, is there was a follow-up to Dynamic 3, or to Dynamic 2, called Dynamic 3. And the long and the short of it was this, unfortunately, did not meet its main outcome of non-inferiority for CTDNA-guided management versus standard management. So stage 2 is where CTDNA seems to feast, which is good because it's a bit of an ambiguous area. Stage 3 disease still need to work out a few kinks, but very exciting.
I think that's the main hurdle with CTDNA, isn't it? It's like it is so promising, but the execution of the ability to prove its benefit is just really difficult.
Yeah, it is. And it is very, very difficult to then, as I said, figure out how we use it and what its place is in clinical practice. And, as with anything, that comes with time.
That's it. Well, Michael, I was wondering where you were going with the tool little reference, but it was a good one. And so next week, we're not going to use any tools for that particular episode, but I think we keep going in the colorectal space. We're talking about rectal cancer, and then I think we're back to more colon cancer, I believe, after that.
Yes, I confess to stacking the amount of colorectal cancer we have, the number of colorectal cancer episodes, and yet I apologize for nothing. So
then we'll move back to breast cancer.
Yes, back to breast cancer and back to GU cancer. No, we're not. We've done all of those, but there's a lot of colorectal cancer coming up over the next few weeks, and we hope that you keep on following us on our YouTube extravaganza that will be coming up. And if you want to listen on Spotify or Apple, then do that. Hopefully it's not like oral torture.
I think we'll eventually get it up on Spotify and Apple. It's just, I don't know, 2 old men trying to figure out technology. Let's go with that.
Yeah, exactly. You'll hear us furiously typing away on keyboards.
That's it. All right. Well, I'll see you next week, Michael.
Bye. Thank you for listening to this episode of Oncology for the Inquisitive Mind, produced by ADC Productions, with the assistance of education grants from Pfizer and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you liked this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts and much more, at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com, and if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.